So, hello everybody from Ljubljana. My name is Marko Hawlina. I'm a professor and head of neuroophthalmology and retinal dystrophy service here in Ljubljana in an eye hospital. And with me here is Assistant Professor Martina Jarc Vidmar and Dr. Lea Kovač. And from Belgrade, we will have Dr. Sanja Petrović Pajić, and we will be the faculty of today's talks. We would be very happy if you would have any questions for us during the talks or after the talks, and we will cover today Leber hereditary optic neuropathy from the beginning up to the treatment. And we would now like to start, so I would give the podium to Martina to start with her first talk.
Dear ladies and gentlemen, it's my great pleasure to talk today about genetics and pathogenesis about Leber hereditary optic neuropathy. What is Leber hereditary optic neuropathy? It's a severe progressive mitochondrial disease with acute, painless, bilateral, usually sequential visual loss that leads to irreversible legal blindness in majority of patients. Mostly these are young men. 90% of them, they have the mitochondrial mutations 11778, 3460, or 14484. This is found in about 90% of all the families. More men than women are affected. The average age is in the middle years, so between 27 and 34 years of age. However, there were reports of patients as young from 6 years to 81 years. Down here, you can see how normal people see, and on the right, you see how people with LHON see. They have a big central scotoma that's white color. There is misty vision like fog obscuring their visual field. They don't see colors well. If you want to understand LHON, we first have to understand mitochondria. These are cellular organelles found in most of our cells, and their main function is energy production. They have a specific structure. There is an outer mitochondrial membrane, then the inner mitochondrial membrane that you can see here. It's yellow color, and it's folded inwards to form cristae to increase the surface of the inner membrane. And inside here is the matrix. In matrix, we find the mitochondrial DNA, and there are also very important enzymes involved in respiration. As I said, the main function of mitochondria is energy production. Here we have the same mitochondria. Here is the matrix. This is the inner mitochondrial membrane, and this is the intermembrane space. The inner mitochondrial membrane is most important. Here we have 5 protein complexes, 1, 2, 3, 4, and 5. And they are very important for oxidative phosphorylation. We see that NADH and FADH donate high energy electrons, which are here shown as small stars, and these electrons shuttle along the mitochondrial respiratory chain. And the energy that's released can be used to actively pump protons, which are named as H+, from the matrix through the inner mitochondrial membrane to the intermembranous space. And ATP synthetase, this is the protein complex 1, then uses the gradient of these protons that is generated across the inner mitochondrial membrane, and with this, the ATP synthetase can synthesize ATP, which is the energy source for all our functions. What happens in LHON? In LHON, most mutations occur in the complex 1. As we can see here. So all these mutations affect genes that encode for different subunits of complex 1. The most common mutation is 11778, presented in 50 to 70% of patients. 14484 is the second most common in 15 to 30% of patients, and 3460, the least common, 5 to 10% of patients have it. The 14484 it has the most favorable prognosis, as some of these patients with these mutations can have spontaneous visual acuity recovery. All these mutations cause mitochondrial defects, which cause problems in the eye. Retinal ganglion cell dysfunction occurs, and this leads to profound vision loss. Why are retinal ganglion cells so susceptible? Because they are unmyelinated before they cross the lamina cribrosa, and they have really high energy demands, and inside you can see higher numbers of mitochondria. So these high numbers of mitochondria makes them particularly susceptible to mitochondrial disease. But eye is not the only organ that's susceptible. What can we have besides LHON in mitochondrial diseases in eye? We can have chronic progressive external ophthalmoplegia, so we can have ptosis and problems with ocular movements, as the eye muscles are also consuming a lot of energy for their function. We can have some form of retinal dystrophies. This is called chronic progressive external ophthalmoplegia or Kearns-Sayre syndrome, if the retinal dystrophy comes with it. We can have also optic atrophy due to LHON. Some patients even have cataracts. As I said, it's not the eye that's the only problem in mitochondrial diseases. It's many organs. The ones that are most consuming are the heart. So many patients have cardiomyopathy, they have conduction blocks. So we have to be really careful, for example, when operating patients with chronic progressive external ophthalmoplegia for ptosis, as we may cause a conduction block. Then we have the nervous system that's also really consuming a lot of energy. So eye is not the only problem in mitochondrial diseases. LHON is most often a maternally inherited mitochondrial disease, although recently other forms of inheritance have been described. Mitochondria, as we saw in the beginning, contain their own genomes. They are in the matrix of mitochondria. This is so-called mitochondrial DNA. Children inherit mitochondrial DNA only from the mother, not from the father, as you can see nicely in this family tree. It's the mother female carrier. She passes mutation to all her children, and the daughter further to all her children. Again, it's the daughter that passes it further, and again the daughter. And when the male is carrier of mutation, they don't pass the mutation further. Why? Because mother's ovum is provider of cytoplasmic contents, which contain several numbers, 100 intracytoplasmic mitochondria, and are causing the disease. A second form of inheritance has recently been described. This is so-called autosomal recessive inheritance, and Sanja will talk more about that. The one that's most described is Knight 330 disease. It phenotypically looks like LHON, but it has somehow more benign course. So to conclude, what are the main characteristics of mitochondrial DNA? It's this typical maternal inheritance, random segregation, and heteroplasmy. So not all patients have the same form of disease. Not all carriers manifest the same symptoms due to variable tissue heterogeneity, due to genetic and environmental influences, due to some immunological aspects, some stress from the environment, medications, toxins. They all contribute to disease varied onset and progression. Here I will stop with this talk about genetics, and we'll start talking about the clinical picture of LHON. If you have any questions, you can ask now, or you can ask at the end of all our talks. LHON was first described in 1871 by ophthalmologist called Leber. It's a rare, severe, progressive mitochondrial disease that causes, as we said, acute or subacute, painless, bilateral, usually sequential, rapid loss of central vision. So usually young men are affected, rarely women. Average age is 27 to 34 years of age. We should think about Leber when we have patients with bilateral painless optic neuritis. irrespective of age. The diagnosis is primarily clinical, so it's very important that you recognize it. And in our cohort of patients, some of them, 5%, may experience spontaneous visual acuity improvement. LHON classically presents with acute or subacute painless central vision loss first in one eye, with vision loss in the second eye weeks to months later. Severe loss of central vision and legal blindness usually occurs within 1 year of disease onset. We already described how these patients see. So they see the mist or fog obscuring their vision, and they see fading of the colors. There is often a long delay to the diagnosis of LHON. Why? The retina may look entirely normal in the beginning. In about 20 to 40% of the patients, the only thing that we see is the hyperemia of optic disc. These patients might have normal pupillary reactions, and they don't have any pain on eye movements. They may be referred to a variety of different specialists before LHON is suspected. When do we think about LHON? When there is lack of visual recovery, when despite the corticosteroid treatment, which is usually given for optic neuritis, these patients don't get the vision back. And when the second eye is affected, then we have to really think about LHON. So patients are referred to neuro-ophthalmology specialists, to neurology specialists, and finally, LHON is suspected. What's the differential diagnosis of LHON? As we said, the vision loss in LHON is subacute, so we have it here. More acute loss is seen in optic neuritis. We can have some specific forms of optic neuritis nowadays, anti-MOOC and anti-aquaporin antibodies neuritis. We can have subacute visual loss with mitochondrial optic neuropathy. The inherited form is LHON that we are talking about today, but we can have also some form of acquired mitochondrial neuropathies, toxic and nutritional neuropathy. I will talk about this in a minute. If the disease is slowly progressive, we have to think about glaucoma, some compression diseases, or autosomal dominant optic atrophy. This is also mitochondrial optic neuropathy, but it has a much slower progression. We should not forget about some form of maculopathies that may have completely normal fundus when just looking with ophthalmoscope, but the things change when we do, for example, autofluorescent imaging or when we do electrophysiology. As I said, I will talk a little bit about tobacco, alcohol, and amblyopia. This is now a rare type of optic neuropathy, but it used to be a common diagnosis before. Now it's more a diagnosis of exclusion. There are two different entities, alcohol and malnutrition, so low levels of vitamin B, complex level, low level of folic acid. This is so-called nutritive optic neuropathy. And the other one is tobacco abuse, where etiology is not clearly understood, but it seems that smoking has effect on oxidative phosphorylation in mitochondria. They all have common clinical characteristics as LHON. There is, in both diseases, subacute onset of bilateral visual loss. Patients have problems with color vision. They have bilateral intracecal scotomas and decreased contrast sensitivity. There is selective damage to papillomacular bundle in both of the diseases and similar underlying pathology. However, in patients with tobacco, alcohol, and amblyopia, they usually gain the vision back when they have abstinence of alcohol and when we substitute B12 and folic acid. So we always have to think about this disease. We have to check B vitamins, we have to check folic acid, and we have to also check the hemoglobin values. We have to ask about other family members and to do the genetics test. So we have to check for LHON genetics and ask about other family members. Why are we talking about tobacco, alcohol, and amblyopia? Because in Slovenia, we had some patients that live in northeastern parts of Slovenia on the border with Hungary, where they have a lot of vineyards and almost everyone has a wine cellar. And we first thought they have a tobacco, alcohol, and amblyopia, But later, we found out by asking about other family members that there are many, and we did genetic testing and found that they have a typical LHON mutation. The clinical features of LHON can be divided into three phases. Presymptomatic phase, which is seen in the carriers, acute phase, which is further subdivided into subacute and dynamic, and typically we have visual acuity loss, and then we have a chronic phase with optic atrophy and legal blindness. In the presymptomatic phase, the clinical features can be observed in some patients. They have usually no visual acuity abnormality. Visual field shows only minimal central visual field changes. Sometimes we may have some loss of color discrimination, and on the fundus, we might see some telangiectatic vessels around the optic disc. In the acute phase, we have this rapid bilateral vision loss, which is painless. The second eye is usually affected into weeks and months. The visual acuity is 6/60 and is getting slowly worse with time. The visual field shows central scotomas. Patients have color visual impairment. If the disease is bilateral, they might have normal pupillary responses. And on the fundus, we see vascular tortuosity and optic nerve swelling. And in the chronic phase, we said we see the optic nerve failure and patients get legally blind in a year. Here we see patients in this acute phase. The subacute, we said it's from 0 to 6 months, and dynamic from 6 to 12 months. And this is the chronic stage. Here we can see typically the optic disc failure. In the dynamic phase, we can see some failure temporarily. In the acute phase, we see this typical triad of ophthalmoscopic signs that we should not miss. We see the circumpapillary telangiectatic microambliopathy. We see the tortuous retinal vessels on the fundus, and when we do fluorescein angiography, there is absence of leakage on fluorescein angiography. How do we confirm the disease? As we said, family history is very important. Then we have to think about the age of the patients. Usually these are young men, but as we said, this might be children or older people. We do in all visual acuity, color vision testing, visual fields. We expect a typical central scotoma in the visual fields. We do OCT, fluorescein angiography. All patients get cranial neuroimaging to rule out differential diagnosis. In Slovenia, we do electrophysiology testing in all of them, and we do genetic testing to confirm which type of mutation it is. Usually, we have these three typical mutations found in about 90% of families. However, in 10% of patients, we might have some rarer genetics. This is our patient. We see this fluorescein angiography, early and late phases, no staining of the optic nerve. When we do OCT, we can check the retinal nerve fiber layer around the optic disc, or we can check the ganglion cell layer in the macular area. This is a very important slide. Why? Because on OCT, we might see changes already in this presymptomatic stage when patients have still good visual acuity. Here you have the visual acuity of one eye, of the other eye. You see that visual acuity, it's in Snellen numbers, so 10 means 100% vision. You can see that already here in preclinical stage, you can have some ganglion cell loss that starts around the macula. This is the other eye when you can see it. And on the retinal nerve fiber layer around the optic nerve, you see normal fibers, and in some patients, you might see this pseudoedema in this presymptomatic stage. When there is a conversion to symptomatic stage, this is here on the right, so when patient starts to lose vision, you can see on the OCT very nicely how the ganglion cell loss is progressing and how the optic nerve failure gets more and more from the temporal part to the whole optic nerve. We see the retinal nerve fiber layer thinning. Here are the months, 1 month, 2 months, and here 1 year after the visual acuity loss. And you see that after 1 year, you have in both eyes ganglion cell loss and retinal nerve fiber layer loss. Another method that we use is electrophysiology. Pattern ERG is a response that checks the function of the macula, this is the P50 wave, and the function of optic nerve, this is N95 wave. It was first shown by Professor Holder that pattern ERG can show changes in Leber patients. Another method that we use is VEP, which we have the not nice amplitudes and prolonged latencies of VEP in Leber hereditary optic neuropathy patients. These are normal controls, and these are patients first shown by Professor Holder. We see the abnormal VEP and absent N95 response. Here you have a normal pattern ERG with the P50 and N95 response, and you see that in the patient, this N95 response is gone. N95 response is showing the function of ganglion cells. In this patient, this was 6 months after the acute vision loss, so patients already had optic disc failure. We did a study in Slovenia on 8 patients with age of presentation from 11 to 30 years. They were mostly male, head MRI was normal, visual field in all of them showed central scotoma, Ishihara was abnormal, and we did electrophysiology in these acute stages, on average just 5 weeks after the visual acuity loss, and we saw abnormal N95 component in half of the eyes, whereas VP was abnormal in all of the eyes. And at follow-up, pattern ERG after 1 year was abnormal in all the patients. So when we are not sure about what type of optic neuropathy it is, pattern ERG may help us to define the disease may be LHON. Now I will show one of our typical patients. He came at the age of 20 years with worsening of vision in his left eye. 1 month before admission to our hospital, he was treated in a local hospital as they thought it's neuritis, so he got corticosteroid treatment, but the vision didn't get better. And after a few weeks, he started to lose vision also in his right eye. When he was admitted, this is the visual field of the right eye. We see a typical central scotoma here, and on the left eye, we see that it's even bigger central scotoma in the left eye. Fluorescein angiography showed no leakage, MRI was normal. These are the other visual fields. This is of the left eye, this is of the right eye. His color vision was abnormal. We did the electrophysiology. Here you see the flash ERG, which is normal in both eyes, and pattern ERG. The right eye, this is the better eye, still shows some preservation of N95, but here N95 is gone, and we see that this form of this pattern ERG is different, that it's not so steep course between P50 and N95. VP is delayed and reduced in both of our patients. This patient was part of a bigger family where his grandmother lost vision at the age of 58 years, and he had a cousin that lost vision at the age of 11. We did the genetic testing for all 3 mitochondrial mutations, but we didn't. Finally, we found that this is a novel variant 13042, and we have published this interesting family just a year ago. This is the cousin of the patient. He lost vision at the age of 11 years. And this was his visual acuity at admission, so hand movements, and on the other eye, visual acuity was 0.3. And again, we see that there is no N95 response, first in the right eye, and later, when we have optic atrophy bilaterally, there is no N95 response in either eye. What's the visual prognosis in LHON? The prognosis is relatively poor, as the majority of patients will remain legally blind. Most patients will suffer severe bilateral permanent visual acuity loss. There is sometimes spontaneous visual acuity improvement in about 5% of the patients, and patients with mutation 14484 have the best visual prognosis, as you can see here. Then the patients with 3460, and the least favorable prognosis is 11778. Additional positive prognostic factors are if patients are younger. They say that if children get LHON, they might have a more benign course. if there is subacute presentation, and when the optic discs are large. To conclude, LHON is a rare heritable genetic disease. There is typically no pain on eye movements. We should think about the disease with all patients with so-called bilateral optic neuritis, irrespective of the age. We have typical clinical features and some atypical cases that Sanja will talk about. There are 3 major mitochondrial mutations found in 90% of patients. Recently, autosomal recessive inheritance has been shown. Prognosis is relatively poor, however, it's better in this 14484 mutation, and confirmation of LHON by genetic testing should be carried out as soon as possible, as then the treatment can begin and we can see the whole family and help the whole family. Thank you very much for your attention. This is the red flag that we should all remember. So males, young males, painless vision loss, 2 eyes affected, and pseudo-optic disc edema in the initial stages. And don't forget the family. Thank you very much for your attention.
Thank you very much, Martina. We'll need to transfer the presentations to Sanja Petrović Pajić in Belgrade. Sanja did a PhD in Leber hereditary optic neuropathy with us, and she will today present atypical pictures, which in Slovenia are quite frequent.
Hello, everyone from my side as well. So my name is Sanja Petrović Pajić, and I'm going to talk about atypical LHON presentation and prevalence. So the topics that I would like to cover today are some atypical characteristics in LHON with typical mutations. Then I would like to talk about patients with rare mutations and typical LHON phenotype. Then some atypical LHON characteristics in patients with rare mutations, and then just to touch at atypical inheritance and autosomal recessive LHON. So the population of Slovenia is as atypical as it gets. We have only 17 primary mutations and 2 autosomal recessive LHON patients. There are 6 patients with rare mutations, and we discovered 3, maybe even 4 large LHON families, but the genetic testing is still ongoing. With Slovenian population of 2.1 million, this makes the prevalence of LHON in Slovenia 1 to 81,000, which is really low in comparison to prevalence in Europe, which is about 1 to 50,000 according to recent meta-analysis. But if we count all the possible LHON patients from large families, the probable prevalence of LHON is 1 to 44,000, which is similar to the prevalence in Europe. Male to female ratio in Slovenia is again very odd. It's 1.9 to 1 or 2.2 to 1 if you count all the possible cases. Just a brief reminder, the prevalence in reported prevalence of LHON in Europe is something around 5 to 1. The percentage of the primary mutations in Slovenia is again very, very low. It's around 73% and 87% if we count all the possible LHON cases. This is also different in comparison to data published for the primary mutations in Europe, which find these mutations responsible for even to up to 97% of all symptomatic LHON cases. So I'm not going to bother you with typical LHON characteristics. They are all very well known, and we heard from Martina about them. I just want to say that the diagnosing process in LHON is challenging, even when things are typical, but when they are not, it gets even harder, and often mistakes are made. So let's get started. Typically, mitochondrial dysfunction in LHON affects only retinal ganglion cells, but extraocular symptoms have been occasionally reported in LHON patients. Of course, the Harding's disease is a very well-known entity. That's the combination of multiple sclerosis and LHON, where the symptoms of both illnesses occur together. There are many case reports in the available literature addressing the issue of the extraocular features in LHON. One of the most atypical cases that I found is a case of a young girl who had the disease onset, which is confirmed by optic disc atrophy when she was only 8 months old. The second eye involvement happened when she was 12, and she developed some extraocular signs as well. In our cohort of Slovenian population, we had only one patient with extraocular features. That's the patient with presumed Harding disease. This patient is a female, and she was 23 when she experienced severe visual acuity drop on her right eye. She had some oligoclonal bands in cerebrospinal liquor and was diagnosed with MS. But she had no visual acuity improvement on corticosteroid therapy. 6 months later, she had visual acuity drop on her left eye as well, but it was followed by complete recovery, only to experience a second visual acuity drop 1 year later, and this time there was no improvement on the corticosteroid therapy. What's interesting is that this patient experienced visual acuity improvement to 0.2 12 years after reaching the nadir visual acuity of counting fingers. So typically, LHON is a bilateral disease, usually subsequent in 25% simultaneously bilateral, acute or subacute. But slowly progressive cases have also been described in LHON. Dr. Barboni and the group of authors have reported a slowly progressive course of the disease in children, but in adult population, this is very rare. I have found only one case of a slowly progressive course, which has been described in one female Korean patient who had visual function deterioration and pattern RNFL and peripapillar RNFL thinning on both eyes during a course of 3 years. So typically, the other eye is usually affected within few weeks, up to 12 months in 97% of LHON cases. But unilateral cases and cases with delayed onset on the other eye for a couple of decades even have also been described. This time difference between the involvement of the two eyes could be explained by the possible presence of a larger number of mutated mitochondrial DNA in one optic nerve, or by the fact that mitochondrial expression in the other eye is increased after the attack on the first eye, thus compensating the energy defect which has developed. In our cohort, we had 3 patients with presumed childhood amblyopia on one eye, which experienced and who experienced the severe visual acuity drop on the other, previously healthy eye, at the age of 7, 21, and 61, respectively. We cannot but wonder whether this really was amblyopia or it was a childhood onset LHON with delayed onset on the other eye. Many diseases can mimic LHON and lead to diagnostic delays. There are many cases in the available literature addressing differential diagnosis in LHON. We've heard a lot, some of the things from Martina, and one of interesting cases will be covered by my friend, Dr. Lea Kovač. And how deceiving can LHON be is well presented by this case. It's a case of a 17-year-old boy who had profound visual acuity loss on his left eye and was misdiagnosed as a tumor of the stellar region due to some chiasmal compression seen on the MRI. 2 months later, he experienced the visual acuity loss on his right eye as well, and he was sent to neurosurgery department because they wanted to surgically remove that mass because they think it was growing. But on the repeated MRI, there was no mass. There was only benign Redcast cleft cyst. He was later on diagnosed with LHON. So this is a case of a patient from our cohort who had bilateral visual acuity loss at the age of 57. At presentation, his visual acuities were bilaterally counting fingers and both optic discs were pale and atrophic. So we performed CT and MRI of the brain, which showed 3 by 4 centimeter big ischemic lesion in the right occipital lobe. So it was thought to be a cortical visual acuity loss. During a course of a couple of months, patient experienced further thinning of peripapillary RNFL on his right and on his left eye. So is this a cortical blindness? We did find an ischemic lesion, and the patient had some atherosclerotic changes in his intracranial and carotid arteries. But why do we have atrophic optic nerve, which is not typical in cortical visual impairment? Also, we have unilateral ischemic lesion, and then why do we have a visual decline on both eyes? So we did the testing, which showed one of the three primary LHON mutations. And with detailed anamnesis, we discovered that a couple of years ago, his cousin also lost visual acuity on both eyes, also late in his life. This patient was misdiagnosed as toxic optic neuropathy because he's the owner of the vineyard, as Martina mentioned, and he drinks and smokes a lot. Of course, when we genetically tested the cousin, he was positive for the same mutation, and this is how we discovered the second largest LHON family in Slovenia. Typical characteristic of LHON is pseudoedema without leakage on fluorescein angiography, but unfortunately, there are some cases in the literature describing leakage in LHON patients. I have found 3 to be precise. This is a case of a 32-year-old guy with 11778 mutation, which had leakage on fluorescein angiography in the acute disease onset. Then a case of a 28-year-old male who also had visual acuity loss and leakage on the fluorescein angiography in the acute phase, first on his right eye and 6 months later on the left eye. His brain MRI was normal, lumbar puncture was normal as well, and there was no improvement on the corticosteroid therapy. This patient was tested and positive for 14484 mutation. 15 months after the disease onset, there was an improvement in the visual function, which is, as we all know, the most common in 11484 LHON mutation and is not characteristic of the optic neuritis. And this is the third case, a case of a 42-year-old patient. Here you can clearly see that there is a leakage on the fluorescein angiography. In our cohort, we have a patient with rare mutation and heteroplasmy 65%. This is probably the de novo mutation because his mother and brother were negative. So what's typical in this patient? He was 53 at the moment of the disease onset, and there was a leakage of fluorescein angiography. So this is the FA of the patient at the moment of the disease onset on the left eye. As can be seen, there is a leakage on fluorescein angiography in the late stage of the angiogram. So we cannot but wonder whether this is an atypical presentation of LHON, or is this the optic neuritis that triggered the LHON. 3 months later, this patient lost visual acuity on his right eye as well, and later on he had complete atrophy of both optic discs. So typically, visual prognosis in LHON is bad, but up to 50% of untreated mitochondrial LHON patients have some degree of visual recovery. As you heard from Martina, the better prognosis is associated with childhood onset LHON, larger optic discs, mutations 14484, and subacute disease onset. Autosomal recessive LHON also has a much better prognosis. This is again the patient from our cohort, a 17-year-old boy with the rare mutation, which was also found in his mother and sister, who are unaffected at the moment. So what's typical about this? What's atypical about this patient? He had 4 episodes of visual acuity decline and improvement on his left eye during the course of 8 months. And after 2 years of legal blindness, he started to improve, and during the next 5 years, his visual acuity reached 0.5 and 0.7 Snellen. There was some improvement in the visual fields, but there was no structural improvement whatsoever, as expected, of course. So 3 primary LHON mutations account for more than 90, even up to 97% of symptomatic LHON patients. Additionally, MitoMap reports 19 rare mitochondrial DNA mutations which are now associated with the LHON phenotype, and 18 others which are candidates. Those mutations are present in single cases or single families. In the population of Slovenia, we discovered 1 previously published rare mutation and 4 novel changes in 5 patients. These changes have not yet been published in the available mitochondrial DNA databases, nor have been present in Slovenian mitochondrial DNA database with more than 8,000 genomes. Pathogenicity of these changes has been confirmed by mitochondrial function testing. And this is one of the mutations we reported. Martina mentioned mentioned the mutation in her talk. Similar mutation, but with different amino acid change, LN to threonine, and different phenotype was published by Professor Kareli and his group. So we reported 2 patients. They are cousins with disease onset at 20 and 11 years. Both of them are carriers of 1304G2T mutation. The same mitochondrial DNA change in homoplasmic state was confirmed in both their mothers and was confirmed in the daughter of the 3rd sister. Both mothers, so sisters, were not affected, but their mother was. And unfortunately, she passed away and we couldn't test her. So this is the proband. He had typical LHON phenotype with central scotomas in visual fields. Then he had hyperemic optic discs, and he had pale and trophic optic discs in the chronic phase. Electrophysiology was also typical with reduced pattern ERG-95 wave and delayed and reduced VP-100 wave, which became undetectable in the chronic phase. This similar phenotype was present in his cousin as well. And just to touch the atypical inheritance, up until recently, we thought that LHON can be inherited only via X chromosome. But nowadays, we know that identical phenocopy can be inherited by Mendelian rules, and it is called autosomal recessive LHON. The autosomal recessive LHON has been associated with several genes, amongst other NDUFS2, MCAT, and NDUFA12. But the most common is the autosomal recessive LHON caused by mutations in DNA JC30 gene. Briefly, 3 homozygous mutations in this gene cause severe complex 1 deficiency and development of autosomal recessive LHON, which has identical phenotypical characteristics as mitochondrial LHON. In our cohort, we had 2 autosomal recessive LHON patients. First case is a 17-year-old boy who was admitted due to a bilateral sequential visual acuity loss, first on the right eye and 3 weeks later on the left. Upon admission, his visual acuity and color vision were decreased. He had hyperemic optic discs, central scotomas in the visual fields, and some staining of the optic discs in the late phase of fluorescein angiography. Similar was the phenotype of the second patient in our cohort as well. And just to conclude, some countries like Slovenia are atypical. They have atypically high percentage of rare mutations. Rarely, some atypical features like unilateral disease, delayed onset, slowly progressive disease, involvement of the other organs, leakage on the fluorescein angiography, etc., have been described and associated with LHON. This complicates the diagnosing process a lot. What would be the take-home message? So first of all, diagnostic process in LHON requires multidisciplinary approach. Even in case with atypical characteristics, genetic and detailed clinical testing should be performed. And please keep an open mind. LHON is full of surprises. Thank you for your attention.
Yes, now the microphone is on. Thank you, Sanja. Thank you very much for this overview of atypical cases. As you see, leakage on the disc should not actually put you off the train of Leber hereditary optic neuropathy, which is often the case. If we see leakage, we think it's inflammatory, it's infectious, and so on. And in the end, basically, LHON, as Sanja said, is full of surprises. We need to actually pursue in searching for mutations, even if they are rare, and try to actually prove that they are pathogenic, and that's not an easy task. So I will now focus and touch a little bit on electrophysiology. This is something that is not so common, so I would go into basics in the beginning. So we would discuss electrophysiology testing in terms with relevance for LHON and also in combination with OCT. And we would try to give you some impression of what we can actually get from electrophysiology in these cases, and some ideas how electrophysiology can actually monitor possibility, which in Leber luckily exists, that this condition can actually improve, and whether or not electrophysiology can help us in understanding the reasons of this improvement and also the objective follow-up in these patients. So as we know, in Leber hereditary optic neuropathy, retinal ganglion cells are primarily affected. This is quite a different condition to optic neuritis, where you first have axonal damage and then retrograde degeneration to the ganglion cells. Here, ganglion cells are actually those which are primarily affected because of respiratory problems of these ganglion cells, and primary disease is actually within the retina, really, not the optic nerve itself. As in small number of patient recovery may occur, we would like to actually follow up whether or not we could see any changes in electrophysiology and describe possible mechanisms. Some time ago, Kareli and his co-workers were looking at these cases, and they attributed possible improvement to remyelination of the optic nerve. And when Bertolt Pempt, who is also present today, I'm very lucky to hello Bertolt, published his first paper, which actually surprised all of us, that even in chronic stages, you can actually get improvement after the even on a treatment. He suggested that there must be some, remaining ganglion cells which are a little bit sleepy or non-apoptotic yet and can be revived with idebenone. So that's how he explained possible mechanism of improvement. Sorry. So we were discussing all these stages already. So subacute stage up to 6 months, dynamic stage 6 to 12 months, and chronic stage, which is further than 12 months or 12 months onwards with advanced atrophy. And in all these cases, we actually can do electrophysiology. We do it with electrodes that are described by us in our clinic in 92. HK electrodes, and this is ERG, which is standardized by ICEV, and ICEV has standardized 5 flash responses. First is maximal response, which means this is a dark adapted retina and with a bright flash stimulation, and then rod response, which is dark adapted retina but very dim flash. And then oscillatory potentials, which gives you information about hemacrine cells, and cone responses, which are responses on a light-adapted retina with even brighter flashes, so that you get cone responses and rod suppression. And then you have 30 Hz flicker, which is response mainly attributed to cones, which can actually follow the frequency of 30 Hz, whilst rods cannot do that. However, it's important to remember that this is mass responses of the retina, and macula is not very well represented in these responses. Then another interesting feature is the flash response, which is called photopic negative response, and it is following B wave, and it's a negative response which goes all the way down. And this is a response which is a flash response, so you don't need fixation of the patient, which is good. And it gives you the summation of the remaining ganglion cells. And you can see that in Leber hereditary optic neuropathy, this photopic negative response is decreased. And then we have multifocal ERG, which will give you topographical map of outer retinal function. So it will give you topographic map of, let's say, photoreceptor dominated response, which is macular dominated response. That will give you information about photoreceptors and bipolar cells. It has actually no connections to ganglion cells. This is a response which is very useful to differentiate from maculopathy. If you're suspecting there is a maculopathy or neuropathy, if you have decreased multifocal ERG, then you're dealing with maculopathy. If you have multifocal ERG, which is normal, like here, and patient doesn't see, then you are dealing with optic neuropathy. And for discerning optic neuropathy, you need pattern ERG. And pattern ERG, as described before, it's a checkerboard pattern, which is moving black and white alternating squares. And this pattern ERG gives you information about ganglion cells. And about, let's say, 80% to 90% of ganglion cells will respond with this N95 wave, and some will respond on P50. So P50 is more photoreceptor response, and then 95 is probably exclusively ganglion cell response. So we are looking at this N95 wave to decide whether or not we are dealing with outer or inner retinal problem. And then we have amacrine cells, and amacrine cells are in between the bipolar cells and ganglion cells, and they modulate connection between bipolar and ganglion cells. And these cells are believed to be origin of oscillatory potentials. And oscillatory potentials are potentials that are not quite well understood. There are a number of them. It has been shown in the past that they are very sensitive to vascular problems, initially in diabetic retinopathy. But however, if these cells are connecting to ganglion cells, and if ganglion cells are dying cells in Leber hereditary optic neuropathy, we should be interested about the function of these direct contact cells, which are actually amacrine cells by oscillatory potentials. And what we could see is that with flash responses, the mass response of the photoreceptors and bipolars in the retina, as shown by the A and B wave, is not very different. And also, if you look at a group of oscillatory potentials, control LHON is in red. They are a bit smaller here on the group response. And we were interested whether or not this will change with the frequency of the filters that we are using with them. Just to finish with the electrophysiology story, pattern BP is recorded with the same signal as the pattern ERG, but electrodes are put on an occipital cortex, and then we can judge actually whether or not and how fast the information has reached the occipital cortex. So now we have the whole setup of electrophysiological responses that tells us about the retinal function. And usually in Leber, all these responses will be normal except pattern ERG. And we will see about the oscillatory potentials, which I will talk a bit later. And it was already shown by Martina and Sanja that this classic and typical response even in early stages, in acute stages, there's no atrophy at this moment. Here, it's a subacute stage with still hyperemic discs at the moment. What you see here is that N95 is already very much reduced or even absent, whilst BEPs are delayed and almost extinguished. And why is this interesting? Because this is a biomarker of early affection of the ganglion cell loss. If you were dealing here with optic neuritis, this pattern ERG would still be normal because you would need at least 2 months for retrograde degeneration to actually decrease the response of the ganglion cells if you were dealing with optic neuritis. But here you are dealing with primary ganglion cell disease, so ganglion cells are affected even if you have no atrophy as yet. So as Martina mentioned, we did a study a couple of years ago and published it, in which we found that 7 out of 14, so 50% of patients in acute stage had already abnormal pattern EIG without evidence of optic neuropathy. So reduced pattern EIG can actually be early biomarker for Leber's hereditary optic neuropathy if you are not sure whether you're dealing with Leber's or with optic neuritis. Now, my gender and co-workers in Moorfields have done an extensive study comparing pattern EIG with photopic negative response, which have been actually photopic negative response for some time very popular because it's easier to do than pattern EIG, especially if the patient does not fixate very well, which is typical for Leber hereditary optic neuropathy patients, because pattern EIG requires good fixation. So PHNR in their study unfortunately was not so sensitive as pattern EIG. It was actually 40% of patients that had PHNR within normal limits, even if the patients were already in advanced stage. So PHNR unfortunately is not as sensitive as pattern EIG. So what we were looking a little bit further now is that we wanted to see in the proof that improved, that had spontaneous improvement, how electrophysiology is different to the patients that did not improve. So we compared electrophysiology and OCT between these two groups, and we compared the situation in acute phase and in chronic phase. So what we could find that the ratio between N95 and P50 wave in acute and chronic phase actually was significantly different. In the patients that improved, this ratio was significantly higher. So N95 wave was better preserved. And when we looked at the PHNR responses, we could also see reduced PHNR in these patients, as you can see here. However, this difference was not so clear to be used clinically, and it was less significant than N95 P50 ratio difference. And when we looked at oscillatory potentials, what we found is that oscillatory potentials were also reduced in LHON patients. And however, that was not the case in all oscillatory potentials. You have up to, let's say, 5 and so on. So clinically, you are looking at OP2, OP3, OP4. And what we found is that OP2 is the most sensitive, and it was significantly lower in LHON as compared to control group. So oscillatory potentials could be an interesting biomarker of LHON. And when we compared, the speed of response of oscillatory potentials, now if you set the lower cutoff of 50 Hertz, of 75 or 100 Hertz, you get cutoff of the slower responses of the ERG. You only get the highest frequency responses, which is 100 Hertz. Then you start to see that the difference is bigger with the faster components of the oscillatory potential. So it means that ganglion cells cannot actually, amacrine cells in Lebers cannot actually follow these high frequencies while they are still quite well following the lower frequencies, as you would suggest actually that amacrine cells are faster firing cells than, of course, as we know, bipolar cells. And these differences became more and more significant if we were getting with the higher frequencies, and that was published last year in Documenta Ophthalmologica. So to summarize, electrophysiology in Lebers would be characterized by normal rod and cone EIG. Pattern EIG would be reduced, predominantly N95. BEP is reduced and delayed and often extinguished. And PHNR is useful when pattern EIG is not available or when fixation cannot be maintained. About 50% of cases show N95 reduction already in the acute phase as a new biomarker, and oscillatory potentials are reduced more in faster frequencies. Interestingly, we were trying then to correlate this with some findings in OCT, and it was published by an Italian group that in a nuclear layer, in an outer plexiform layer in Leber, actually becomes thicker over time than the normal controls, which was quite interesting. And we were able to confirm these findings. Moreover, we find that in the group of Leber hereditary optic neuropathy and genetically caused group of non-Leber hereditary optic neuropathy, you could see that in Leber's you have this green part here, then the central part of the retina is better preserved than in non-LHON group of patients. So that was also published 2 years ago by Sanja and us. And what we could see is that also in our patients group, those that improved had better preservation of GCC in the central ETDRS grid, and also ENL thickness was better preserved in the group that improved. So there is some structural basis of this improvement. And as was already shown, there was one patient that is interesting to illustrate all this, what I said today about these mechanisms. There was this patient which had DNA JC30 mutation, and he improved spontaneously over time. And his story is quite fascinating because he was losing vision progressively, as you can see, for quite some time. And then 14 months after the onset of disease, vision started to improve a little bit. And then 4 years and 6 years after the disease onset, actually it improved quite well. And even 10 years after the disease onset, his visual acuity came back to 0.7. Although you see that OCT did not show any improvement, and atrophy was actually progressing. And you can see this over time in N95 latency and amplitude. This is Petrović that he improved over time according to his visual acuity, which is shown here, and also his P100 latency and amplitude. So BEP P100 latency and amplitude improved over time, which was quite interestingly, and you can see here on the waveforms, initially you have loss of N95 and very much delayed BEP. Now you can see a little bit of improvement of Petrović and also quite some improvement in latency and amplitude of BEP. Also, as you can see, 2009 is here. It's oscillatory potentials in the squares, and 2017 you see this improvement of oscillatory potentials in these patients. So to conclude, to give it a take-home message, look for early loss of N95 amplitude in acute stages. It should be a good differentiation between Leber hereditary optic neuropathy and optic neuritis. Improvement of P100 peak latency, timing latency and amplitude, and N95 P50 ratio should be followed up as the main electrophysiological characteristic for spontaneous or actually drug-related visual acuity improvement, and improvement in OP oscillatory potentials and N95 amplitude. This actually suggests some remodeling going on in the inner retina, and it's probably that some function of the ganglion cells that are dying actually are being taken over by hemacrine cells projecting to optic nerve. So this story about oscillatory potentials is on the beginning. This is our first paper on that, and nobody else actually looked at this specifically. And we will be looking at the correlations between the OCT and the outer plexiform layer thickening in Leber. And yes, improvement of P100 wave may be suggesting also what Carelli and others suggested, some remyelination of optic nerve, or maybe just increased retinal output. And just to thought-provoking paper, it was interesting to find that this remodeling was also studied by other authors that presented this on ARBO and suggested that perhaps hematocrine cell may replace, at least in part, dying retinal ganglion cells. Thank you very much for your attention. And I would like to ask Lea now to present this case.
Hello. So my name is Lea Kovač. I work in neuro-ophthalmology department here in Eye Hospital in Ljubljana. And as Professor Hawlina just said, I will present an interesting case of toxic optic neuropathy mimicking LHON that presented in our clinic. So a 28-year-old male presented to our clinic with blurry vision, hearing worsening, and paresthesias. Personal history was predominantly relevant for chronic cystic fibrosis in terminal stage that was scheduled for lung transplantation and had a recent exacerbation. Furthermore, he was on a prolonged course of antibiotic treatment for secondary complications of cystic fibrosis. On examination, we found a bilaterally reduced visual acuity that further diminished during the course of hospitalization. The color vision was impaired. The color vision was impaired, and there was a central scotoma found on perimetry, as we can see here. On fundi, we could see hyperemic swollen discs and vessel tortuosity, and retinal nerve fiber layer thickening, and also initial macular ganglion cell layer loss, especially in both eyes. In fluorescent angiography, there was no visible dye leakage. Electrophysiology showed a normal pattern ERG in both eyes, but poorly formed and P100 wave with lowered amplitude in both eyes. We performed a full diagnostic workup for bilateral optic neuropathy that was largely normal apart from peripheral sensory polyneuropathy of gloves and socks type that was found on neurology examination. So our differential diagnosis based on this clinical findings was first Leber's hereditary optic neuropathy. As we can see, it typically affects young males. It is bilateral painless, causes subacute visual failure, and all the other clinical presentations that are typical for Leber's were present also in our patient. So we conducted genetic testing for hereditary optic neuropathies. This testing was negative for typical LHON mutations, but it did reveal a novel variant in OPA3 gene, which was of unknown significance, and genetic segregation was advised. OPA genes encode mitochondrial structural proteins and therefore can also cause mitochondrial dysfunction. Previously described mutations in OPA3 gene were connected to autosomal dominant optic atrophy and cataracts, and also included hearing loss. But optic dominant atrophy usually presents and has a more insidious course, so this didn't quite explain the findings in our patient. So we looked further if there could be a cause in his primary disease, so cystic fibrosis, which is autosomal recessive pulmonary disease, and usually causes mutations in cystic fibrosis transmembrane conductance regulator gene, which encodes a transmembrane chloride channel. Usually, this is also thought of as a dysfunction of a transmembrane chloride channel. However, recently it has been found that reduced CFTR activity in cystic fibrosis cells actually reduces mitochondrial ND4 gene expression and therefore can reduce mitochondrial complex 1 activity. Furthermore, early cases of optic neuropathy in children with cystic fibrosis were described in the early 50s, which were attributed to prolonged chloramphenicol treatment that was used in that time. This was later attributed to chloramphenicol toxicity, and later it was also found that antibiotics can cause a drug-induced toxic optic neuropathy, and hypothesized mechanism is a disruption of mitochondrial function. This effect was most commonly described in linezolid, which is thought to inhibit the synthesis of ATP in mitochondria, and the described cases also were presented with bilateral hyperemic disc edema, vessel tortuosity, no dilatation on fluorescent angiography, and peripheral neuropathy, as it was in our case. So actually, there were three factors that could contribute to mitochondrial dysfunction in our patient. Firstly, the OPA3 variant gene, cystic fibrosis, and reduced pulmonary function that downregulated mitochondrial synthesis, mitochondria ND4 gene, and antibiotic toxicity. So the treatment was targeting all three of the possible causes. The patient received already previously planned lung transplant, which obviously improved respiratory function and his overall health. We discontinued linezolid and ciprofloxacin. We started him on supplement therapy with vitamins and included idebenone. After 5 months, he came for a follow-up. In the meantime, he was recovering from the lung transplant, so he couldn't present to follow-up earlier. But he reported that his visual acuity actually started to improve already a month after discontinuing antibiotics. And at examination, his best corrected visual acuity was 1.0 in Snellen. His Sihara plates were full, and perimetry showed only minimally reduced sensitivity, as seen here. The fundi showed a completely normal discs with less vessel tortuosity. On OCT scan, however, there was a moderate macular GCL loss visible. We repeated electrophysiology examination, and we saw that the pattern ERG-N95 wave was slightly diminished in the right eye in agreement with greater ganglion cell loss, but visual evoked potential signal was completely normal, and which showed improvement in optical nerve transmission. So in conclusion, I would like to point out that patients with cystic fibrosis might feature a mitochondrial dysfunction and could therefore be at a higher risk for mitochondrial optic neuropathies. Variants of OPA3 gene may be an additive factor to cause clinical features of acute LHON, and antibiotics should definitely be considered as a possible environmental triggers for disruption in mitochondrial metabolism, especially in genetically susceptible individuals. The mechanism of antibiotic toxicity could also be taken as a possible model for Leber optic neuropathy, and to use it in further research, maybe in animal models. So this case was published. This case was recently published. So all the more detailed description can be found on this link. Thank you for your attention.
Thank you very much, Lea. Okay, I'll try to be brief because we are a little bit over time. I would just give a glimpse of counseling and treatment, not go into details about this. We've seen this slide, and we actually know now that at certain points we need to decide on different types of examinations and approaches. So if you see somebody in acute stage, then you would need to do all differential. If you see somebody with the chronic stage, then the options are probably less diverse. Now, if once you get the genetic diagnosis, then patients would usually ask us, what is the possibility that other members of the family get affected? And this is really not easy, because even if the Leber hereditary optic neuropathy has mutations in mitochondrial genome which are homoplastic, then a number of studies have shown that these homoplastic mutations are not present in different tissues with the same percentage, and it's really difficult to find out what is the percentage in different types of tissues. And so we see situations when you have somebody who has, let's say, homoplastic situation with 100% of affected mutated, 100% of affected mtDNA, and then you have a group which may be, or a patient that has low percentage of affected mtDNA mutation, and you would suggest perhaps that they have better prognosis. However, in the studies, it hasn't been shown that this is the case, because even those which have low percentage of mutant mtDNA can have, as I say, higher percentage of mutant DNA in the optic nerve. And that has been actually shown on the postmortem studies, that even in patients with low heteroplasmy, with low percentage, you may have very high concentration of mutated DNA in the optic nerve itself. So genetic counseling in labors is extremely difficult to say who will and who may not actually get the disease in the group of the, let's say, offspring. And we cannot really predict the persons at risk. So we are not suggesting that they should be taking any, let's say, prophylactic treatment or any other measures of that. So then the next question would be, is it possible to predict conversion from clinical signs? And the answer is again no, although it was already many years ago published by Nikos Alain, who was actually one of the first authors to describe Leber hereditary optic neuropathy in detail, that half of the asymptomatic maternal relatives will have some degree of microangiopathy. However, they did a very long follow-up study, more than 20 years, prospective follow-up study of these individuals showed that very few of them actually have really developed the disease. So we couldn't really be judging by the, let's say, degree of microangiopathy that we can see on the patient's fundus. Then Lea talked about, and also Martina, about precipitating factors. In addition to mtDNA mutations, there are other genetic or environmental precipitating factors, especially the gender. For example, we still don't know what is the reason why male have higher preponderance to disease development, and still we don't have any candidate gene to explain why this is so. There have been some studies about the possibility that sex hormones will actually modify the disease course, but actually has not gone to the levels that we would actually justify any estrogen treatment, for example, to males that would, with the idea to reduce the possibility to develop the disease. So there are also non-genetic factors like smoking and alcohol, and that has been suggested many years ago already, and recently by Giordano with a very extensive study, which probably proves that especially smoking, tobacco smoking, is one of the very important risk factors, although some case control studies in the past showed that actually that might not be the case. So it's really something that we still don't know exactly. That's the study of Giordano and associates that has really probably persuaded us that cigarette smoking is a serious risk factor. So I already said that it's impossible to predict conversion for percentage of heteroplasmy, and that has been shown that asymptomatic homoplasmic and heteroplasmic patient had similar course of disease once the disease has broken out. But again, we are not actually putting this aside, and a lot of prospective studies now, especially with development of OCT, are in progress to start to see whether there are some changes. Are there some biomarkers that could tell us that some patients may be more at risk? And one of these has been just recently shown in Valencia, and 1 year ago in Leber, that optic nerve head dimension may be a biomarker, but it's mutation specific. Once it is too small and one is too large, different mutations, so we are not quite sure what actually is a biomarker here. However, this needs a longer follow-up to see whether these patients will develop the disease. We have been discussing the rate of spontaneous partial recovery, and as Martina already pointed out, G11778 have the best prognosis in spontaneous recovery, and T11484 and G3460 have lower percentage of possible spontaneous recovery. And we are now talking about how do we, terminologically correctly express improvement. So these are some terminology terms that we are now using. So clinically relevant recovery, clinically relevant stabilization, and clinically relevant benefit. Well, where clinical relevant recovery is at least 10 letters of ETTRS chart, or if you go off chart, on chart, you would have at least 5 letters on chart. That would be relevant recovery. Relevant stabilization would be if somebody would not lose vision below 1.0 logmar, and clinically relevant benefit would be a sum of clinical relevant recovery and stabilization. So what are the treatment options that we have in the moment? First of all, prevention with avoiding smoking, alcohol, antibiotics, as we heard from Lea, illicit drugs, and so on. Genetic counseling to some extent, just to, let's say, behaviorally adjust their lifestyle. And then idebenone, which is a derivative of coenzyme Q10, which has ability to better penetrate in mitochondria. So if you just take coenzyme Q10, which is sold in the pharmacy, sold over the counter, that may not actually enter the mitochondria at all, and that's why idebenone has this ability of entering the mitochondria and therefore having better effect. And then gene treatment only for the G11778 mutation so far, and this has been shown to have moderate effect, but however, unfortunately does not prevent the second eye involvement, even if the treatment is started before the second eye loses vision. And then a number of other drugs that have been showing some, let's say, neuroprotective effects, like brimonidine, and coenzyme Q10 again, and many others actually. There are quite a lot of them, vitamins and so on. However, they have not reached clinical significant level. And there's another question is what not to do and what not to take, especially stem cell treatment, which is advertised now in a number of countries, especially China, India, some also in Germany and Switzerland, unfortunately. These treatments have been advertised by intravenous application of stem cells, which of course cannot really know where to go, and especially even if they would come to the optic nerve, how would they know which cells they need to connect with the axons of the optic nerve? So this is really at the moment not a viable treatment, and has to be the patients have to be informed that this should not be done, because it can also be harmful and especially expensive. And also hyperbaric oxygen, that is not good, because it's not a problem of hypoxia. We have enough oxygen in the optic nerve. However, if we do hyperbaric oxygenation, we would increase the percentage of reactive oxygen species, which are actually harmful to the optic nerve. Now, idebenone have been tested in 3 clinical trials. Now the 4th is coming also on the end of talks. So first was RODOS, and then extended RODOS protocol, and then LEROS, and idebenone 300 milligrams orally 3 times daily was first in RODOS done for 6 months, and then extended protocol to more than 20 to 34 months. And now we have a LERO study, which also included a control group, which this extended protocol didn't have. And what the results showed is that, contrary to what was expected, that idebenone would have immediate effect, actually that the idebenone showed effect which was delayed and showed good proportion of improved patients even up to 3 years, and now we know even longer. And now we see that these curves are actually increasing with time. So now, of course, this first, let's say, guidelines that was first proposed by the Leber hereditary optic neuropathy expert group has to be rewritten, and it will be rewritten in terms of treatment that is obviously effective also in chronic stages. How much is the vision improving? Let's say it depends on the mutation, obviously, but let's say approximately 35 letters would be a mean improvement of this treatment over time. However, it's interesting that idebenone has some mutation-specific effectiveness, and has been in LEROS and also PARO studies show that there are mutation-specific changes in the effectiveness, whereby in mutation 1178, idebenone was more effective than in 14484 mutation or 3460 mutation in chronic stages. And also it showed that it's possible that 3460 mutation in subacute stage may actually do a bit worse if given idebenone early. So that's something that are now looked into very specifically, whether or not it might actually, in this rather, let's say, smaller group of patients in subacute stage, idebenone may not be beneficial, but that was not shown in chronic stages. So in chronic stages, it behaved similar to other mutation. Is there any age-specific effectivity of the studies? Yes, it is. The LERO study has shown that idebenone may not be effective in children, and children do a bit better already spontaneously. But if idebenone was given, it was shown that reduced frequency of visual recovery was actually seen in this treatment group, so it's not recommended for children in early stages. In patients over the age of 18, it did not really behave any differently to adults. In chronic stages, that results were pretty similar to what we see in adults. It's early treatment really essential, as we have been preaching for many years. We may not see that really, and this is the slide from the last UNOS, which was just a week ago in Rotterdam, and this is Valerio Carelli, who published most of the seminal papers on Leber hereditary optic neuropathy from this part of Europe, and he showed in group from Italy and Germany, and these are here. If you don't, of course, we will not see that it's not treated. This is early treatment. That's pre-onset, and that's subacute group, and this is chronic group. And if you do visual acuity, the better is below. So you see that the best result was actually found out in chronic stages, when idebenone was given in chronic stages. And this, of course, is not corrected to the follow-up, but it shows that perhaps we are not missing a lot if we don't start very early with idebenone, and that idebenone still has good effect in the chronic stages. Now, how is gene treatment working in Leber's? That's quite a complicated story. Why? Because we cannot inject, because we do intravitreal injection of AAV. So this is the special virus which contains the correct sequence of the mitochondrial DNA, but this one would not actually enter into mitochondrial cytoplasm. Actually, the entrance to mitochondrium is impossible directly because it has double membrane. And what then needs to be done is to actually do nuclear DNA modeled sequence, which would then on the membrane transform into a working or normal protein that could actually enter the mitochondrium. So the entrance to mitochondrium is not so easy. And 2 studies so far have been done, one up to 6 months, and then the second one, which is called reverse. Reverse was up to 6 months, and rescue was up to 6 months, and reverse was prolonged to 6 to 12 months. And what this study showed that we do have some moderate effect, which is unfortunately not in the beginning where the disease starts, but it's gradual and actually enduring, and that in about 70% of patients, we do have like mean improvement of about 26 ETDRS letters in these groups of patients. So you can see here over time that these 2 patient groups actually do differ. So with treated, that's more than 88% of improvement, whilst there is non-treated 48%. Interestingly, if you put this together, that was again the slide from the UNOS meeting that was presented by Nancy Newman and Patrick Uyman. What this slide shows is really nicely showing the effect of these treatments. Now here, if you see this, my mouse, this is the group that is not treated, so 175 patients, and the group that is treated by idebenone, and the group which is treated, So that's the group not treated, that's the group which is treated with idebenone, and the group that has had genetic treatment. So you see that both of these groups are better. So this is meta-analysis of all the patients that have been treated either by idebenone or by genetic treatment. So you see that there is some effect, however, the effect is still limited. Now, interestingly, as already been mentioned, with February 2022, we started to see all these cases that we believed it phenotypically typical Lebers, but we couldn't find the mutation. And now we are getting more and more of these patients, especially in Eastern Europe. These are these recessive Lebers, so DNA GHC30 defect. And when we are seeing more and more of them, we also see, luckily, that this mutation seems to be less harmful and that has better percentage or better prognosis than with mitochondrial DNA variants. And that's why we need to separately study effects and separately study actually natural history of this group of patients. And late spontaneous recovery, as we showed you before, in the patient that had like 7 years of latency after the decrease of vision of actually legal blindness came back to 0.7, which is quite interesting. And we don't know whether or not Idebenone may even be more effective in this group. That's not been done separately. So what other types of treatments are in the pipeline? It's protection of cardiolipin. That's one of the components involved in the metabolism of mitochondria, and acetylcholine has been implicated as having good effect on that, also in other diseases like glaucoma. Then oxygen radical scavengers and mitochondrial targeted gene therapy. That's the one that doesn't actually target the nucleus, but directly mitochondria with this CRISPR-Cas new methodologies, but that's really still far from the clinical use. And as it's already available in Australia, nuclear transfer. So if you take the nucleus from a zygote, then you take nucleus out and put it into another cell which has another cytoplasm. Then you have this so-called three-parent baby that will decrease the possibility of getting the disease for the offspring. So just to go back a little bit to our group, what we are doing here and what our main goals and invitation to collaborate is. Our group, as you've seen, is active in research in genetic and other types of optic neuropathies. And we do focus on atypical optic neuropathies, as Sanja has outlined, and especially interested in early biomarkers of improvement and rare mutations and recovery mechanisms, and any collaborative efforts in this very rare clinical conditions is welcome. And we also welcome patients' initiatives with labels, and especially would like to point out this website that is taking you to an excellent website, giving you all the information about the disease, and also Slovenian counterpart of that is interested, was our representative Marko was also listening to us, presented at last yearly meeting of ERN-EYE group in Ljubljana in Slovenia last year in March. And we hope with the combination of, let's say, joint efforts of all these centers, we will come up to have better solutions for the treatment. And that's a group picture from Ljubljana in 2023, really a brain tank of European Union to actually try to bring new ideas and new treatments to these patients. Thank you very much for your attention, and we are open for questions.